I think first and foremost, let me thank uh, thank you for agreeing to be expert in our panel, and I hope you're speaking from Goa and not from Europe.
No, I'm home now.
Okay. Let's first ask Chetna to have a quick introduction about herself, her practice, and where she is, etc., etc.
Yes.
Okay.
Chetna, the mic is with you.
Good evening, everyone. Let me introduce myself. I'm Dr. Chetna Naik, and I have been into this vertigo practice since, say, maybe 2007 onwards. And earlier, I was practicing in Pune, where I had my own vertigo clinic, and then eventually I moved to Goa. So presently, I am in Goa in Margao. Since the last 6 years, I have my own setup practice, and mainly I practice neurotology, and I have the Cyclops VNG with me, and so this is how it has been. And last 6 years I have been practicing over here. Earlier on, I was with a medical college as well. I have been a professor and head of department in of Siangad Institute Medical College, that is SKNMC in Pune. And but then since I've moved to Goa, I'm no longer attached to any medical college, but I'm into mainly into my private practice. So that's how it has been. So today we will be discussing an interesting case which Anusha has been very kind enough to
So,
present.
not
Yeah. So, sir,
Yeah.
you'll continue with your moderation.
Okay, so no, you got to get used to my style of moderation. So my style of moderation does not end here with you. I just want to say that you were the star attraction in the Barani Society meeting in Sweden, right?
Nothing like a star attraction or anything, sir, but it was a great
Okay, you
meeting.
were the attraction,
And
one of the stars.
no, I got the opportunity to go there, and it was really something. It was really nice. I mean, that was always my dream, going to Uppsala. So it happened this year. That was great. And the good part was I also happened to meet my son, who is there. So that was two in one.
Great.
Yeah.
So, Dr. Anusha, would you like to tell us something about yourself so that people know you?
Myself, I'm Dr. Anusha. I'm a beginner in neurotology. I'm working with Cyclops from around 1 year, and I'm practicing general ENT also at my own clinic in the Bangalore.
Okay, so Anusha, you have an interesting case which you want to share with us.
Yes.
The floor is yours, please.
Yes. Today's case is like BPPV as a complication of vestibular migraine along with triple PD in a young female. So I'd like to start this presentation. Sir, is my screen is visible to you, sir?
Yes.
Yes, I can see it.
Yes.
Yeah, go on.
Yes.
Yes, sir. Okay.
Yeah, we can
So,
see.
yes, sir. A 20-year-old female patient had come with complaining of non-spinning imbalance or swaying since 10 years. Like she came with a long history of this balance disorder, like saying there is no exact spinning sensation, but I'm feeling some imbalance and swaying since long back from 10 years. She's suspecting that it is related to some fall from bike with neck injury, which happened long time ago, that is 10 years back only. So she's suspecting that caused this balance problems. Then onwards, I'm having severe problem with daily activities also, like that she is complaining. And recent history of like 10 days, from 10 days, she's experiencing spinning sensation on position changes as well. So further, repeatedly she went to neurologist also. Brain imaging was done, MRI brain, which was normal, and neurologist said it's everything normal only. So one doctor had prescribed antidepressants as well, but she's not very responding to that, and it is worsening whenever she is taking antidepressants. This is the history she came up with. So after taking the full history from her, I have analyzed the symptoms, like she is having some chronic long-standing symptoms, and in between some episodic waxing and waning of symptoms are there. And recent history is separate, right? Recent 10 days history of spinning sensation, that more of positional vertigo she is complaining of. So standing chronic symptom she is having is constant imbalance or swaying, and she's feeling to about to fall while turning sudden turns, and also whenever she is standing from sitting position, she is feeling that she can fall, but there are no history of falls. And in between, episodic waxing and waning of mild headaches she is complaining of. After I have asked for that leading question, like, do you feel any headaches before? She then replied that, yes, I have headaches from adolescence as well. Like it's like moderate pain I used to have. Then nowadays he is having headache along with little bit imbalance or mild spinning sensation as well. Increased symptoms she is observing on prolonged mobile usage, and also like visually sound environment, like very pubs and all disco lights. If she is going there, she is having this increased symptoms. And recent history of spinning sensation lasting for few seconds on position changes. It is there since 10 days only. And along with that, head heaviness also she is complaining from head 10 days. So I thought like she's having vestibular migraine. It might be acute episode of vestibular migraine she is having, or because of she's having constant imbalance and swaying feeling also. So vestibular migraine, maybe it is precipitating into the triple PD or vestibular, and she's typically giving BPPV presentation of BPPV symptoms also recent 10 days. So it might be, I thought it might be vestibular migraine with recent episode of BPPV. Last differential diagnosis I have thought like it might be vestibulopathy due to traumatic brain injury, which she is complaining of 10 years long back. She had some road traffic accident she had given in the history. So that's why I have these many thoughts. It could be. After so I have proceeded to clinical examination because she is having more swaying from sitting position to standing. So first I have ruled out that orthostatic hypotension also. BPPV on lying down and standing, it is like normal values only I got. Ear, nose, throat examination was normal, and hearing also normal. Gait normal, and standing for 1 minute, eyes open, eyes closed, and foam surface also. She is able to stand for 1 minute with very mild swaying, which I generally it is normal. Head impulse test I have done to rule out any vestibular dysfunction, vestibular hypofunction in any side. It came as normal as well. So I proceed to VNG test, video nystagmography. In that, oculomotor tests almost normal, except that very mild saccadic smooth pursuit is there on the vertical plane movement. And there is downbeating spontaneous nystagmus in dark without fixation. There is mild downbeating spontaneous nystagmus. The same nystagmus is present in post head shake, post hyperventilation, and gaze tests also without any increase or decrease in the intensity. And subjective visual vertical was normal. And diagnostic positioning test for BPPV, in that Dixalpic, there is no typical posterior canal nystagmus. It is not there. On McClure Pagnini or supine roll test, we have found typical canalolithiasis of right side. We have geotropic nystagmus. We can see here right lateral side, right beating on right lateral. and left lateral on left beating on left lateral side. So a geotropic nystagmus we have appreciated in, and it is more intense on right side. So that's why we have diagnosed it as right horizontal canal canalolithiasis. Here is illustration taken by Dr. Anita ma'am's simulation workups, just to show for beginners. It is the nystagmus. We can see how it will cause nystagmus in right lateral canalolithiasis. Sit to supine will cause ampulofugal movement. It will have inhibitory nystagmus towards opposite side. On right lateral side, ampulopetal movement of endolymph. So right nystagmus, right beating nystagmus. Again, it is reversing. Left lateral side, it is again ampulofugal movement. So that's why inhibitory nystagmus. So left side, left beating nystagmus we can see. So depending on the intensity, we can decide the side of the involvement. So more intensity in geotropic will indicate the side of the involved canal. So we have diagnosed it as right horizontal canal canalolithiasis. Correction was done by Guffoni Magno. Here we can see sitting on the edge of the table. First position is sitting on the edge of the table towards the examiner. Second position, quickly we have to move towards the good ear. Unaffected side, that means left side. Side lying position, we have to quickly move the patient towards side lying position. And then next, we have 45 degrees towards the ground. We have to move the head towards ground 45 degrees. Then hold this position up to 2 to 3 minutes. Then we have to return to the first position, sitting back. This will correct the canalolithiasis of the horizontal canal, right side horizontal canal. So after this maneuver, we can see nystagmus was completely resolved and positional vertigo also completely resolved. So we asked her to come for follow-up after 5 days. So after 5 days, we have performed VNG and also I have taken history. So she is happy with the positional vertigo, like she is not having spinning sensation at all. But the chronic symptoms are still persisting. So imbalance and other chronic symptoms which she is having, like imbalance and swaying, lack of confidence, all this is still persisting. So we have moved on to workup on the follow-up. So VNG, it is showing same mild downbeating spontaneous nystagmus in dark, and all gaze tests and post head shake and hyperventilation, the same downbeating is there. No positional nystagmus now, and SVV was normal. So subjective questionnaire was taken, like a dizziness handicap index. It is showing like she's feeling that it is causing difficulty in the routine daily activities. So in that questionnaire, we have found out moderate handicap she's having with this kind of dizziness. And hospital-based anxiety and depression scale questionnaire also was taken. In that, we found out that borderline anxiety disorder she's having. And gait was normal. Standing test again was done. She performed well. And stabilometry on postura we have done. Modified computerized test for sensory interaction of balance. That means same test like standing for 1 minute, eyes open, eyes closed, and foam surface. This test on the postura we have done. It was normal. And Romberg's test, in this we'll have free stance and narrow stance and tandem stance, all these with eyes open and eyes closed. all these were normal range only. We have found little bit abnormal values in limits of stability, where she's having more fear to reach the limits in the especially in the front and left side. So she's not able to like she's stopping to reach with fear or some so fear of fall. So that is the only abnormal thing we have noted. But almost she performed well in the postural tests also. So depending on above findings, we have diagnosed the case as vestibular migraine precipitating to triple PD. So what are the key points which helped me to arrive at this diagnosis is we are having some diagnostic criteria for vestibular migraine and triple PD as well. So given by Bharanese Society. Here, at least 5 episodes of vestibular symptoms of moderate or severe intensity should be there. And current or previous history of migraine with or without aura should be there. And one like.
Okay, Anusha, I'm going to interrupt you here. Brilliant presentation till now. But here's where I'd like to ask Chetna. How often in your practice do you see people with multiple pathologies presenting? Dr. Chetna, are you online?
Muted, ma'am.
Yeah, there. Yeah.
Yeah,
So
so-
multiple
yeah.
pathologies is many a times we have to take with a pinch of salt. Like, having so many things together in one patient, we have to really take with a pinch of salt, because we are just, it's kind of becoming like a cocktail, a little bit of this, little bit of that. And, so especially in this case, yeah, definitely when you saw the patient today, definitely there was a BPP. Today means the day you examined, there was a BPP which you have been able to correct it with the maneuver. So we can take it that yes, it was BPPV at that time. And as we know that in vestibular migraine, people with vestibular migraine have a higher chances, 3 times higher chances of developing BPPV in their lives. So this is something which we have definitely come across. I do come across many patients who have had vestibular migraine in the past, and now they have come with BPPV, or maybe they had BPPV episodes in between also, but at that time maybe they never visited a neurologist. Okay, so but a patient, a vestibular migraine with P3D is something I think I don't remember coming across a patient like this. Maybe there might be, if we go deeper into the history, maybe there was migraine in the past, but I don't particularly remember any of my patients having P3D which developed because of a vestibular migraine. I have seen patients with P3D. Mainly, these were the patients who have had a history of similar to BPPV in the past. Means I don't know whether that time anybody diagnosed it as BPPV or not, but definitely I have seen patients who have developed that phobia. It's more of a phobia, phobic. They just don't want to move. They just don't want to do that. These kinds of patients I have seen, and with P3D. So this P3D is kind of a dicey diagnosis which we really don't know, because it has got multiple layers. There's a lot of psychosomatic component as well, a psychological component as well, and it also depends on the personality of the person. If you go into many patients, you'll come across some, they do very well. Like today itself, I had a patient of vestibular neuritis, which maybe few 1 month back she had, but today she's like absolutely fine. But there are also patients who, even after a long time, they are all the time having a swaying, and that kind of thing remains. It depends on the personality of the patient as well. So because P3D has got always has some psychological overlay. So now all these 3 things in one patient becomes a little difficult to digest. But you never know, maybe yes, patients may be coming with this, because vestibular migraine is quite common, isn't it? So
So
that's
here's a follow-up question. In the headache of vestibular migraine,
Hmm.
have you seen a classic migraine type headache, or is the headache of vestibular migraine different in its manifestation than the classical migraine, in your experience?
In my experience, I have had patients who give the typical history of migraine in the past, but many a times patients will not give the history of headaches at all. And then you dig into the history, yeah, it was their headache, but then it is sometimes very vague. I really don't know whether we should consider. But then I ask for the other symptoms like photophobia, phonophobia, and the other symptoms as well, which should go. Then you dig into the history. But a patient typically presenting, yes, we have had patients like that, not at, but in the past, maybe not now, but in the past they have had those histories, especially when women with this history.
My general feel was, I don't know, I could be wrong, that most of the headaches in vestibular migraine were not falling into a clear category. I don't know how. I mean, there's a degree of non-specificity. So, Anusha, in this case, was your patient's headache fitting into the category of classical migraine, or was it not too specific?
After digging into the history, she given that like I had multiple times headaches I used to have in the adolescence, and photophobia and phonophobia also she's complaining of, sir. So
But was it one-sided or anything like that, or was it?
not throbbing pain, not one-sided pain, no
Yeah.
association with nausea also. So those features are not there, sir. So.
So
And
that's my point. Actually, I have honestly yet to see a classic case of that. Go on. Yes, Chetna, you're saying something?
yeah, coming
You-
to the
you-
P3D part of it. So,
Yeah.
should what? Yeah, she had unsteadiness, but all this unsteadiness was there all the time.
Yes, ma'am. That's why, like 24 hours, she is feeling that whenever.
She's feeling swaying types. She feels sway in the head.
Yes, ma'am.
She
Because of
keeps
that, she is.
feeling sway in the head, or
Hmm.
when
Uh,
even when
how,
she's sitting.
so
Hmm.
That's what she is feeling,
how,
but it is more on from sitting to standing position. If she is going from sitting position to stand, if she is standing from chair, then she is feeling more. And while walking, also
Mhm.
she is feeling like swaying. So she had
Mhm.
now she is not having confidence that without any other supports, so another person, she is not able to go outside also. That much history she had given, ma'am. That's why.
so no, so here's my follow-up question on that to maybe both of you all. Um any vestibular problem is usually centrally suppressed.
Yes.
So when you have a persistent problem like this, okay, you can look at vascular causes. Have you looked at cervical causes? How
Cervical
often does
cancer.
cervical cause this? Because you have a history of accident.
So I
And
yeah.
yeah, go on.
I was coming to that because we have to take into account the whiplash or any that kind of a injury she might have had, because she is definitely correlating it with it started after that accident. That's what this patient is saying, so right.
Yes,
So yeah, we could consider that some kind of a whiplash injury or something which happened at that time, which has resulted in see, there are papers on cervical vertigo, not BPPV being cervical vertigo, but actual cervical vertigo, about the stimulation of those nerves along the neck. There are papers on that. There are studies on that. So maybe that could be correlated.
uh,
Maybe.
for that, actually, ma'am,
Okay.
upright position tests are there, no, ma'am.
Uh,
Roll, pitch forward, and pitch backward.
yeah, yeah.
Those
Hmm.
are normal, ma'am. Like there
They
is
were
no.
normal.
Yes, ma'am.
Normal.
That's why I have ruled out that also.
So why did you think of that vestibulopathy after a brain injury? Something you mentioned something on the first slide.
Yes, ma'am.
Yeah.
Last, ma'am, like she is having that.
You meant a vascular episode? You meant a vascular thing, or what exactly?
Sometimes we'll get recurrent vestibulopathy due to vascular compromise, no, ma'am.
No, you meant that after the head injury, how I didn't get that point. The first in your differential diagnosis, you put it. First, traumatic vestibulopathy due to traumatic brain injury. Exactly what did you mean by this?
Because she's strongly saying that after that
Huh, huh, huh.
having this,
But then what injury exactly? How causing vestibulopathy in the sense?
maybe in vascular compromise like that.
That's what you were
Yes, ma'am.
thinking.
Recurrent vestibulopathy episodes can happen with vascular.
Okay. You meant like that. Okay, got it. So,
Okay, so Anusha, back to you. You can continue your presentation.
Yes, sir. So, because of constant feeling of swaying, more on standing from sitting position, and unable to go to crowded places, and lack of confidence in performing daily routine due to fear of fall. These features, because of this, I'm suspecting this is going into triple PD as well because of this psychosomatic features. So management, first I had done like counseling because she is not knowing what I'm going through. So that's why I had explained her what is her problem, and after that I have given medications for migraine like flunarizine 10 mg once daily, and supplements of magnesium and riboflavin coenzyme Q. I have given medications, and also I have suggested vestibular rehabilitation sessions weekly twice for 6 weeks, which includes balance control exercises and 2D games on postura, and also core muscle strengthening exercises, and virtual reality exposure to challenging situations like narrow bridge, high altitude, and supermarket environment tasks. This virtual reality exposure helped a lot because it acted as a cognitive behavior therapy, in which the main intention is to expose the patient to challenging situations, um, and we have to acclimatize the patient to those situations. Cognitive behavior therapy also in psychologists will do the same. So this virtual reality exposure helped a lot in this. So she got confidence after that. These are videos of rehabilitation. After those 6 week sessions, patient was improved very well. She got very confidence also, and symptoms of constant swaying was completely resolved. Even I was surprised, ma'am. So,
So here's, no, wait, I'm going to hold you here. Switch back to Dr. Chetna.
yeah.
When you have multiple pathologies like this, do you treat them simultaneously? Would you like to treat the vestibular migraine separately? Would you like to treat? Because here I've seen a mixture of both being treated simultaneously. Some of the therapies would be more suitable for triple PD than for vestibular migraine. So how
I
do you manage such cases like this?
I would consider treating them simultaneously because yeah, we have to because the patient is not going to come. Patient is coming to us once and hoping for them to follow up. It's better that we start all simultaneously. That is what I would prefer because
And
that
in
will be
your
beneficial to the
vestibular,
patient. Yeah,
yeah,
sorry.
no, go ahead. And in your vestibular migraine treatment, how often do you go step ladder? Would you start with flunarizine? How often do you go step ladder, or do you usually
Yeah.
succeed
So
in getting
initially,
this?
first thing I tell them is about the lifestyle changes, about the food, the dietary part, or that part also I explain to them. And depending upon the severity of the symptoms or whatever, I start them on the medications. Usually, I do prefer to give flunarizine, but then when it comes to the weight issues and all, then some patients I have even given topiramate and magnesium. Yes, I have been using magnesium as well. And some of these patients do have, even now, they if they have history of severe headaches, then of course I give something for that, like headset or what is that, snap it or one of those. But otherwise, yes, I do start the patient. I explain everything about the lifestyle management first, because the moment you tell them about taking tablets, and they know that okay, they have to take for a longer period, they just don't want to accept it. They don't want it. So then you have to tell them other things also, that okay, this is going to be for a short period. After that, by the time you would have managed, you change your lifestyle and all that, by that time you would have got better, and then we would be stopping the medication. So I start with that, the lifestyle modifications, the dietary changes which the patient has to do, reduce the stress. I talk to them about yoga, meditation as well, because finally that also has to be taken care of. And of course, start the patients on the medications. Yeah, but the question is how long. So it is usually just 2 to 3 months, and then I have a follow up and see how they are doing. Most of them do well with the vestibular migraine. They do well
How,
with it.
so how often have you had to go beyond flunarizine?
Not much, rarely. As far as vestibular migraine is concerned, no.
Okay.
Flunarizine has been helpful. Yes, it has been helpful. Yes.
Okay.
The incidence or their symptoms have drastically gone down. I have good follow up of some of the patients. Drastically gone
Okay.
down. They're happy. Yeah.
Okay.
What about venlafaxine, which is a SNRI, which can be used in triple
Yes.
migraine patients?
Yes. I have not used much, maybe just a couple of patients, but because we didn't have much experience with it earlier. But then, of course, we have read a lot about it. I've tried it in a couple of patients, but not in many. No, no, no.
I
Because
thought
So is there,
the SNRIs are supposed to be used. Yes.
no, is there a schedule about prescribing these drugs? Can we prescribe these drugs freely, or is it to be done only by certain people? Is because I think in UK you have a very strict stratification of people who can prescribe this. I have not prescribed, so I just wanted to know, what do you think? If you prescribe, is it honored, or does it fall under label of psychotropic drugs, or what?
We can use psychotropic drugs, of course, but then if you're not very confident, it is always better to take the help of a psychiatrist. Always have a psychiatrist on your panel, or on your have a team. So because there are some patients who may require some kind of a psychotherapy as well, so counseling sessions as well. So but then I think we can write these drugs. I don't think there's any restrictions on that. At least I don't
Okay.
know that. So we have been writing.
Yeah, because I've been a little concerned about the fact that many of the listed side effects are quite high, and I
Yeah.
kind of feel that if I prescribe and send the patient away without any track of this
Uh-huh.
patient, I tend to this is my person. I'm a very cautious fellow.
Mm.
I'm a little cautious about prescribing, so I just thought I know your opinion. But you never had adverse issues with your prescription so far.
No issues. No, it's not.
okay.
Anusha, you can carry on. Good.
So this is the pre-rehab and post-rehab reports. Here we can see she had more limits of stability also. It was normal after post-rehab. She have performed well with confidence also, and there is no spontaneous downbeats also after rehab sessions.
Yeah, the downbeat nystagmus. How do we explain it over here?
That's what, ma'am. I was also surprised to see.
I was thinking in terms of something to do with that trauma, that Arnold Sherry, something like that. Something like that was going on in my mind when you mentioned about that.
But
But
already she mentioned
yes.
neurologist and MRI, everything was done. He told like everything was normal regarding brain and central things. So might be functional issue only.
But then it has gone after your treatment,
Maybe
right?
this is attributed to migraine episode, I feel.
Okay, I was attributing it to Anusha, your uniqueness. Huh? You seem to have sorted his problem. By the way, how old is this lady?
28 years, sir.
28. So she was 18 when she had the accident.
Yes, ma'am.
Mm.
And she is employed, or she's a homemaker?
She is preparing for groups, sir.
Sorry, preparing for?
For IAS exams.
Ah,
Okay.
okay. Okay,
Right.
so
Okay, good. And when did you see her approximately? In time? How many months back did she present?
She was first came to me in this May, sir. On this May.
Oh,
After
okay.
that, July was this post rehab reports were done in July.
Okay.
She
So
was
she's now
after,
followed for about 3 to 4 months,
yes, sir.
right? Okay. So you have to keep a tight watch. And okay, go on. Anything more you want to share? Please go ahead.
Just I have read some articles about it is
Uh,
showing migraine is
no,
associated.
so, no, about this patient, anything more to share?
That's it, sir. She was very
That's
happy and yeah.
So, no, that's fine. I didn't get to eat the laddus which she must have given you. I mean, if I had been through all this, and you had sorted 1, 2, and 3 of my problems. So tell me, how are you following up this case? What are you planning to do?
Uh,
Ananta?
Sir, I have asked her to come after 3 months actually, sir, for follow-up PNG and this thing, but she didn't turn up. But she told she was fine on phone call.
So have you discontinued flunarizine or she's still taking that?
Continued, sir. After those 6 week sessions, I have
Uh,
to slowly taper it down within 2 weeks. So she has
oh,
done.
so she's off medications also.
Yes, sir.
Oh, that's great. So in summary, your positional tests have taken, I mean, your maneuvers have taken care of her canal problem, and your medication has,
Yes,
like magic, taken care of her vestibular migraine
sir. This PPP
and the rest of it.
yeah.
So,
time.
I think that's I don't know whether that's a very common thing to have such dramatic improvements. What do you feel, Chetna?
Yeah, that's sort. It's quite interesting to know that, and especially the P3D part.
Yes.
So yeah, that part is if she's really doing well after the rehab, it's really great having this. And within 6 weeks, you said, right? She was fine.
Twice weekly. Uh,
Uh, you
so,
were doing that rehab twice weekly, and she was following up with you for doing that.
yes, ma'am.
That's really great. That's nice.
He told
Because I remembered one patient, of course, she didn't follow up back with me. There was this lady from Delhi. She had, they come sometimes and they stay in Goa, and sometimes they are in Delhi. Okay, so this lady came and she was, of course, the older age group. Maybe she was in her 50s or something like that. And she was like, she has unsteadiness. She's terrified of standing and walking, terrified in the sense that she walks normally like that, but then when she goes tandem or when she wants to put one foot in front of the other, she says that she can't do it. Like I really didn't understand what it was, and she gives me the history that about a few years back she had gone mountaineering, and at that time something happened and she fell or something like that. She lost her balance, and since then she has been like, I got vertigo since then, and now I'm not able to walk.
yes,
That's whether it's a psychological thing. And I tried to do her unterburgers and tandem walking. She was not ready to put one foot in front of the other. She just stands there, she just freezes, like, no, I can't do it, that kind of a thing. Then I tried to do her rehab and things like that. I had done her VNG also, if I remember well, yeah. But VNG also didn't show anything much. It was almost all normal. And but then they were shuffling between Delhi and here, Goa. So I think I
Yeah,
remember to
I,
here to
I think most people from Delhi are migrating to Goa anyway, so I think you'll soon have her as a chronic patient. Anusha, go ahead. Tell us the theory.
and what are the common VNG findings in migraine patients, ma'am? You have come.
You mean vestibular migraine patients? The
Yes.
VNG finding, see, vestibular migraine is a chameleon in itself. So it depends on when you have done the VNG. basically. So, of course, you may come across certain nystagmus, maybe direction changing nystagmus also. It all depends. It could vary. It could really vary. And yeah, one more thing is your. Mm, I think the optokinetic and all these, there could be abnormalities in the same in optokinetic the nystagmus as well. And so it depends. Sometimes when you are doing the VNG in a history of patient with history of vestibular migraine, absolutely everything is normal. So you can't really pinpoint. So what do you have to say on that? What is your experience?
Like vertical plane smooth pursuit is affecting, ma'am.
Yeah, yeah.
It will be there. And in some patients, SVV will be abnormal in background,
SVP.
with background.
But SVV is, yeah, again, that is really can't say because, you had commented on my SVV paper. Somebody mentioned about the vestibular migraine. It was you? Number of cases of vestibular, the poster, the SVV poster, because I have done my number of patients with vestibular migraine having abnormal SVV was less compared to the other pathologies.
Okay.
So yeah, so
So
that's
they
what I found.
pulling out other things and then
Yeah, I don't know. I don't know. They didn't really show so many. I mean, compared to the other pathologies.
No, but I think the point you made was correct that it depends in which phase of the vestibular migraine you'll end up investigating, because accordingly your findings may vary.
Exactly.
I suppose the benefit of doing VNG is whatever findings you find abnormal, we should make it a point to repeat it after therapy.
Mm-hmm.
That would give
Okay.
us a better indicator of,
Yeah, and that is something
direction
which
in which you take.
we don't generally do because we are like, in your private practice you're really the time and then again the expenses and you have to think of all that again, subjecting the patient to that. But then yes, of course, as a researcher you can do it. One can do it.
I think
And
sometimes patients are quite happy to pay uh, for for something provided it's sold correctly.
yeah, exactly. Hmm.
If you can sell that the need right at the outset. So what we've used this trick, not particularly, I'm not talking in Vertigo, but many cases who require a repeat radiological imaging. You
Mm,
offer a package wherein you don't charge them double, but you
mm,
say if you pay
concession.
1.5 upfront,
Mm,
we will do it twice. So
uh-huh.
that trick
Mm,
might work with these
yeah.
patients. We
So with
offer a slightly
mm,
different deal because then, I mean, quite apart from the fact that you have more to present, but you also have a hold on it. Because what I find is that there's a lot of doctor shopping. So a
yes.
lot of patients shop around. So nobody really, few have, but most of us don't really have a hold on what's happening to the patient.
Mm,
That is something which I feel we somehow in groups like this, we need to address it. Outcomes, because we're all talking findings, like surgical conference, they're all talking surgeries. Nobody is really discussing outcomes or analyzing outcomes in a systematic manner. So I think it's necessary
mm,
for the seniors in the group to start pushing people towards assessing and reporting outcomes.
exactly.
Anusha, you want to share some theory again?
uh, that's its a diagnostic criteria.
Mm.
Go on.
The
And
reading one.
one more question, ma'am. For horizontal canal canalolithiasis, Guffoni manure and barbecue roll manure, which is better, ma'am?
I don't know which is better, but what works good for my patients is the barbecue. That is what I have been doing, and my patients do well with it. And Gufoni is somehow, I don't know, I am more comfortable with barbecue, and this is some work you are giving the patient also to do at home. So, I mean, they have to repeat it, right? So, the patient is also happy doing it. And Gufoni one, I do it at times. It's not that I don't, but my routine, what I do is the Eplees for the posterior semicircular canal and barbecue for the this lateral. This is what I do for the geotropic, of course.
Okay.
And being in Goa, I suppose you have a lot of experience in having barbecues. So,
And it's nice to tell the patient this is like the barbecue. I tell the patient it's like barbecue. So patient don't mind doing it at home also. They are happy doing it. So
right.
and it works well with me. I don't know. That's my experience.
So what about you, Anusha? What do you find more convenient to do to a patient?
We are doing Gufoni, sir. So if they are old and hefty person, then doing Gufoni is a little bit difficult, sir, because it involves quick movement.
Mhm.
In them, barbecue roll method will be better, I feel, sir.
Your preference is for Gufoni.
Yes,
Your preference is for Gufoni.
yes, sir, yes, sir.
Good.
And
You had something. Sorry, you want.
that is also because of the influence of literature only, sir. They are saying that Gufoni is better. That's why, but no experience for me, like which works and which does not work.
Frankly speaking, I have not done any comparative study, but
Mm.
with barbecue roll, they are doing well. So I'm like, okay, I'm doing it, continuing it. It's just that.
Yes, ma'am.
Yeah. You want to share something else?
That's it, sir.
That's it. Okay, fine. So
Just show that
I think
P3D1.
now we should open up this meeting
Yes.
to the
Oh.
attendees also.
Yeah, triple PD diagnostic criteria was like symptoms of dizziness and unsteadiness, non-spinning vertigo. At least it should be there from 3 months.
3 months. Yeah, 90 days. 90 days is the requirement. Yes.
Yes. So it will exacerbate on upright posture, which is there in our patient, active or passive motion, and exposure to moving stimuli or complex visual patterns. And this disorder can be precipitated by conditions that cause vertigo, that can be BPPV episode or a neuritis episode before. So, or any psychological distress, these can lead to triple PD. So, as a precipitating disorder, they have mentioned this. Symptoms cause significant distress or functional impairment.
Yeah, and then you have to rule out any other. That is very important. Just rule out any other obvious other cause.
Yes.
To explain the.
So, because of this criteria, my patient is satisfying this criteria. That's why.
Oh, it fits into this.
Yes, ma'am.
But then, good. She's doing well. The patient is doing well. Good for her.
Yes, ma'am.
Let's open this meeting out in the last 5 or 10 minutes to the participants. Would any of the participants like to share their experiences or ask any questions? Anybody, if he would like to
Who's this?
raise his hands and unmute, you could go ahead and unmute yourself. Okay, so as they say, cats got their tongue. Maybe it's so then.
Hello. Yeah. Hello.
Yes, ma'am.
Can you hear me?
Yeah.
Yeah,
Yeah.
can you hear me?
Yeah. Yeah.
No, I was hoping that the participants would come in to add their wisdom and their experience, but apparently this is dinner time for most people. So I think we'll unwind the program now, but just a few questions, which are one question or two questions, which I'd like to ask you, Chetna. What is your experience on the changing profile of vertigo cases in your practice? When you
Over
compare
the
what you
years, over the
yeah,
years, you mean?
over the years.
Um, uh, Frankly speaking, when we started out, and when we were quite just post PG and all we knew about vertigo was Meniere's disease. Okay, only Meniere's disease. It sounded, it was almost like, yeah, most of the cases are Meniere's disease. But as we progressed, and I think we would also examine patients with the same thinking in mind. Maybe our understanding was not as good as what it is today. And then as the years progressed, we got to know about BPPV. Then we were starting seeing more and more of BPPV, and probably we were ill informed. So
So
and
you
over
mean
the
that it is our knowledge profile which has changed,
yes.
rather than patient profiles which have changed?
I think so. I think so. Really, sir. I don't know.
Yeah.
Maybe yes. The lifestyle changes have changed. Now we are saying we are seeing more of vestibular migraine. Vestibular migraine. Maybe it was always there, but we were missing it. Or maybe this is something. Uh, I really don't know.
No, no,
Maybe.
no.
Yeah.
I
That
think that's an interesting point because I would agree with it that there was a time where there was a catch-all diagnosis called atypical menias. So anything
yes.
which would not fall into a typical menias would be dumped
We
into an
called as
atypical
atypical.
menias.
Yes, the
Right, right.
Lemoyes syndrome and all those things.
Yeah.
We read about them, but now we hardly talk about them, isn't it?
No, so but
And
now
yeah,
now I think triple PD has become the
yes, the
go-to
hot.
diagnosis when you can't fit into
Yes,
any other thing. So in a
yes.
sense, the Barani Society introducing strict criteria has done us a favor because we are now
Mhm.
not in a position to use it as a basket to collect
Basket, yeah, to
cases.
dump. Yeah, and over the years, that is what I have been seeing. Oh, kuch chakkar
Correct.
dikha. Pehle it was manias, then it became BPPV, then came vestibular migraine, and now then came P3D. So that's how it has been. So over the years, so maybe our knowledge is
And
improved,
and
or we
also
have
and,
become yes.
and also I think another lacuna area is the medications we are giving.
Mm-hmm,
Even if you study neurology medicines, see, broadly, every medicine affects some aspect of any cell.
mm-hmm,
So, whether you talk about SSNRIs and, all kinds of these things, they're all quite non-specific in their action.
mm-hmm.
Uh,
Yeah,
Meaning they
true,
act on
true.
specific pathways, I agree. But those
Yeah.
pathways are
Hello.
present in every cell in every part of the brain.
Ah,
So
got
I
it,
think
got it.
these are all, yeah, can you hear me?
Yeah, yeah.
So
We
I
can
feel that
got your point.
there is so much ground to be covered in vertigo that I think it makes this area a source of continuous fascination.
Yeah.
Any other thoughts which you could share, Chetna, especially from your trip to Europe? What do you feel is the European attitude to vertigo in that sense? Do they take it? That they take it much more seriously
They
because
take it much more seriously, and the kind
yeah,
of discussions I saw over there, like I mean, some people, the questions they were asking and the interactions which were happening, it was like beyond the thinking. They really are into it. The people who are doing the research are very rational,
yeah,
and very rational about it, and very much into it.
because
Even the
so
yeah,
that's a
people who came
good
from
point because
China, and yeah, they do that.
pe-
It's
people
very
in
seriously
India,
taken.
apart from a few, tend to be dismissive of vertigo as a major problem. That's been
Yes,
my
yes.
experience. Like they like people used to dismissively say psychiatry is two and a half diseases and two and a half drugs. So that kind
Mm,
of mentality used to be there. But I think the change is good, and
mm,
a lot of the change is the access to instrumentation.
yes.
And of course, people like you who do dedicated work. So I think thank you, Chetna, and Thank you,
Thank you,
Anusha.
sir.
I think
Thank you, sir.
this
Thank you,
has
sir,
been
for
very
inviting me.
interesting. And, if I don't leave now, my marriage is at risk. So I would have to leave you. So
Thank you.
Thank you,
thanks a
sir.
lot.
Thanks, Anusha. And thanks,
Thanks.
everyone.
Anusha, well
Everyone.
done. Anusha, well
Yes.
done.
Thank you, sir.
Okay.
Yeah, Anusha, very good. Very good.
Thank you.
Really. Yeah.
Thanks.
Thanks.
Bye.
Okay.